Good morning, everybody. Welcome to another wonderful rendition of Coach's Corner. I am Scott Linger. I'm a knee and shoulder surgeon with Forte Sports Medicine in Bloomington. And we've been lucky enough to partner with IHSAA to create this webinar. And the goal of this is to just get people together that are like-minded and who want to take care of athletes and our communities. And this has been a great platform for us to just share ideas and share thoughts and learn from each other in our community. So we're very lucky to have Dr. Alvey with us today. He is a sports medicine physician with Forte, mainly works out of the Greenwood Clinic. He's got extensive background and experience with taking care of athletes all levels. He helps with the Colts currently with their sports medicine and primary care needs. And he's going to talk to us today about something that many of us have probably lived through, back pain. I have delved into this much more than I would have liked over the last several years, including a surgery and recovery and all that. And so I'm very interested to hear his thoughts and what we can learn about red flags and treating our athletes and getting them back in the game. So he's got a great presentation for us, and I'll let you take it over.
All right, thank you, Scott. Hope everybody can hear me fine. As Scott said, I'm Thurman Alvey. I'm with Forte, and I'd just like to thank everybody for the opportunity to speak with Coach's Corner, and we'll get rolling. So back pain is a common issue. First of all, just my standard disclosures. This is my opinions. It does not reflect Forte's or the Colts or the NFL. And any pictures you'll see in this are mine or from clip art files online. If otherwise, somebody should let me know and we can take it off. Okay, so we're going to talk about back pain. And back pain is everywhere. Most of us watching this are of age, but we've probably had back pain at least once or more times in our lives. And it often starts in high school with respect to sports. So just kind of roll through what I want to talk about today, talk about the common causes of back pain in high school athletes, understand why history, the mechanism of injury, and specifically where it hurts in their back matters, talk about some basic treatments and concepts of when it is safe or not safe to go back for return to play, and then maybe what we can do to prevent these things from happening in the future. Okay, I'm frozen, sorry. There we go. So where do we start with this? You know, when the patients come into me, and I know there's a few athletic trainers or on the talk, and sometimes it's the coach that hears about it first. You know, did this just start? Is this an acute injury? Is it a chronic injury? Have you had pain for the last 1 to 2 weeks? Did it just start with one practice? It was just after one lift? Really, we need to know how long this has been there, because chronicity matters a lot as we roll through these slides in terms of what kind of pathologies we're dealing with. You know, we want to know, is this a sprain strain type injury? You know, did they pull a muscle? Is it mechanical? Is something catching? You know, is it maybe a congenital issue? Is it a fracture? Everybody worries about a disc. And then what specific risk factors go with these athletes? You know, larger athletes have certain risk factors, as do smaller. Certain sports, any rotational sport, whether it's baseball, hitting a ball, wrestling, gymnastics, anything with hyperextension is going to add risk for certain conditions in the back. Just like loaded spine, the heavier weightlifting, the more dynamic weightlifting, those can all play a role. Or something as simple as a basketball player jumping up to get a rebound and someone crashing down on top of them, which forces flexion. Loaded flexion is a definite risk factor. So why is back pain important? Well, Scott kind of hit on it. We're all going to kind of have this. And I went back and just pulled some more recent numbers, but the American Academy of Pediatrics reports 30 million athletes in sports each year with 3.5 million injuries related to the sports. And that's about 3 years old. So that's a lot of kids playing sports. Back pain is estimated to be between 37 and 66% prevalent in adolescent athletes. That's a lot. I see a lot of back pain in the office. Thankfully, most of the back pain we see isn't surgical, but it is very, very common. 1/4 of all college football players at a recent NCAA poll reported a long-standing history of back pain prior to college, and 80% of adults develop back pain in their life. It's still the third leading cause of doctor visits, according to Mayo Clinic. So back pain is real. Back pain is something that once people get it, they don't take care of it, doesn't really go away. And if you haven't had it yet, I think we should count ourselves lucky. So with back pain, what do we talk about? And I've lectured for the athletic trainers in the past and resident students. It's just like real estate: location, location, location. Sounds kind of corny, but it matters. Is it midline? Are we talking about pain that's specifically on the bone? Are we talking about pain that's in the muscles? Pain that's more along the hips? Pain that radiates up and down? Pain that stays in one spot? Where the pain is located tells us a lot of information. So, what do we watch for? And what would be red flags as a coach or a trainer? If you're on the sideline, you're seeing these kids, are they limping around? Did they have a hard fall or a really specific traumatic event? Something where they go up for a dunk and they're undercut and they fall on the gym floor. The wide receiver jumps up for a pass and gets crunched in his mid-back with a helmet. The lacrosse player that gets smashed between two players. Even someone in soccer that looks like a simple slide tackle, but they bounce off the turf a little bit. These traumatic injuries can really cause fractures and or disc problems. If there's pain that persists for more than 2 weeks, that's usually when I tell parents and when I tell trainers, if you've got a kid, freshman high school, junior high school, middle schooler, and they've had pain for 2 weeks, you really want to figure out why this is hurting and what's going on. It may be more than just a simple muscle pull. Any numbness or tingling, any weakness that goes down, of course, any neurological dysfunction we see there, and specifically pain at night. Kids that, for the most part, they're all resilient, they're tough. You take a Tylenol, take a Motrin, a little ice, they're ready to roll the next day. But when they report, I can't sleep at night because of my pain, that's something we should pay attention to. And this was reported back from National Federation of High School back in 19, so I'm not reinventing the wheel here. This is a common list which is out there and easy to find. So when they say my back hurts, I ask them, what do you mean your back hurts? Tell me how would you describe this pain? And most of the time, that just feels tight. The high school athlete that comes in, they don't give us a lot of things to work on sometimes. It just feels tight, doc. It's tight. It's kind of right down here, right where that picture shows, kind of right down here in this area. It's in here somewhere. They may say, I feel weak. I was lifting and when I turn now, I feel weak turning back the other direction. Every now and then I feel stuck. I can't turn because it's stuck. And these are the kids where they've got some type of facet or mechanical issue, and we have them see physical therapists or chiropractors or osteopaths, and they can manipulate this and kind of put it back in place, because sometimes it is that simple where there's been a mechanical shift. Sometimes a kid says, my back only hurts when I move. I sleep at night, I feel fine. When I run, I feel okay, but when I twist left, it hurts. But it really hurts when I touch my toes. Again, all of these things direct us towards other symptoms. It aches all the time. You don't want to hear that again. Pain at night, we just talked about. So strains, sprains, mechanical pain, discogenic neurologic pain, and chronic pain. This is kind of when I'm going through it in my mind and I see these patients, what I break it down to for the high school athlete. And when you think about it, really about 15 to 20% of what I see in the office each year is usually a pulled muscle or pulled ligament. The gymnast that has a hyperflexion injury, they're going to strain sometimes interspinous ligaments. The weightlifter that's going a little heavier too soon, he's going to pull a muscle. The person that's gone through an extra round of batting practice because he's got extra batting practice on top of his regular scheduled high school batting practice. He may whiff a couple of times and pull one of his lats. That hurts. Mechanical symptoms, this is again about 10 to 15%. This is often the facet disorder. They respond very quickly to treatment. Thankfully, the discogenic neurologic with the burning, the tingling, the weakness, this is pretty rare. 5 to 10% of what I see in the office. And then the more chronic, this is a lot. About 200 times a year, I see people in the office that come in with congenital issues, whether it is some type of incomplete fusion or full lumbosacral fusion or a stress fracture. So it's very, very common, at least in this office. I understand it's somewhat of a biased population because by the time they see me, they've already been to their high school trainer, their family doc, maybe their chiropractor, may have already seen a physical therapist. So it is going to be a little more loaded. I understand that, but we're upwards of 200 to 250 a year in this specific patient group. So again, when I talk about this, take a good history as a trainer, as a doctor, because you're going to really know what to find. The exam is not overly complicated. We're gonna look and see if there's anything out of place. We're gonna poke around and palpate. Do a good neuro exam. look for range of motion of upper extremity, lower extremity, do our strength testing, any provocative maneuvers that we've learned all through school. Again, this is more for the trainer's perspective to do that first assessment, makes my job so much easier. And you know, sometimes kids come in and they present with, I've got a hamstring problem. I've had this hamstring problem for 3 months. And I know I had a kid this year, he's been dealing with a hamstring problem since track season last year. Well, it turns out that his hamstring didn't get better with his previous provider, didn't get better with me. We dug a little deeper and I said, do you ever have back pain? No, I've never had back pain. And he had hamstring issues on MRI actually, where he came to see me. We dug a little deeper. Well, sure enough, he's been dealing with a chronic disc herniation that was radiating pain down his hamstring that he wasn't able to verbalize. And I didn't do a very good job looking back, initially evaluating that. Same way with scapular issues for cervical pain and other pains coming down. So the acute sprains and strains, these are often traumatic in nature, mildly traumatic. You know, this could be, as an adult, we slip on the ice, you lose your footing, you plant on the wet turf, you do get crunched in a football tackle like this, you have an explosive run or jump, you do lift too heavy, you're going to do a maximal day and you're really not ready for it. Poor body mechanics. The other thing we get with acute sprains and strains, this would be the athlete that has just gone a little too much. You know, they're overtraining, or they're going to get 1 or 2 more reps. They're still really fatigued. I think I can go a little further, and they don't have the muscular integrity to prevent themselves from getting injured. Again, sprains, this is more of a ligament. I chose the lumbar ligament down here because we see a lot of these, but it could be any ligament along the posterior or lateral edges of the spine, whether it's interspinous. A lot of low back and hip pain I see is related to lumbar ligament, especially with rotational athletes. Just like an ankle sprain, sprains are what I call like injuries to life. You know, you stretch, you tear, you overwork the ligament, you know, and some type of body weight falling or twisting. It can be very minor to even an emergent if you have a complete sprain type tear. How do we get sprains and strains? Usually from a bad warm up. And it doesn't matter whether you're a colt athlete that I'm seeing or whether you're a high school athlete. It's actually probably worse than the early retired 55-year-old male, but nobody warms up is my point. Nobody really takes the time to warm up. There are some schools and some strength coaches that do a great job of this, but we want to get out, we want to exercise, we want to finish our exercise, then they got to go study, they've got to do other meetings, they want to talk to their girlfriends or boyfriends, or we want to get back to our kids in life. So good warm up is so important in kind of preventing the sprains and strains. You know, having better flexibility, having better conditioning, and again, we talk about dehydration and exertion. So how do we treat these? This is pretty basic. Again, trainers do an awesome job of this. Just protect it, rest it, ice it, compress it. Good old Price mnemonic. It works very well. I like this because this is what I tell them. You know, grab something for your back. You can have a gel pack, you can have frozen peas. You can make your own ice bag like this. Put that on your back, wrap it on your back, lay on your back with that behind you. This works the same principle. Everyone I see knows how to do this with respect to ankle. Surprisingly, very few acute back injuries take the time to do this because they don't, well, I don't have a big ice pack at home. Well, you don't have to have a big ice pack. You can use whatever you have that's available. Just get it cold. So let's talk about disc. You know, the disc injury, as I said, really isn't that common, thankfully, in the high school athlete. But when it is, we sort of know acutely because it is hot, and they talk about this unbearable pain. They don't feel right. Usually, it's related to lifting from what I've seen the last couple of decades in the high school athlete. But it can happen with about anything, any type of force flexion. One of the worst disc injuries I've ever seen was a college athlete who had someone fall on her back, and she kind of got crunched in half, and she had 2 discs herniated at the same time, and she had surgery 2 days later. So, you know, weakness is what we worry about. This picture here, we see there's a little disc down here that's protruding. Again, just kind of a quick review. We've got nice vertebral bodies. The disc quality looks pretty good all the way through at 4.5, at 3.2, all the way up a little Smorl's node kind of here, so you can tell this is an adolescent type athlete with some congenital change. Cord and space looks wonderful until we get right down here at 5.1. We've got this little bulge coming back, and there's a ligament showing we're still in place. Doesn't look bad in this view until we go to the next view, and here we see it's a little more significant. So this is actually the same patient, and you know, unfortunately, he tried, and we just could not get him back where he was able to perform, and he ended up having microsurgery and did very well and finished his high school career. But you know, he was just to put it bluntly, miserable. And it didn't matter what we did from a physical therapy perspective or from a rehab perspective. These kids are pretty unhappy, and they're easy to spot. The chronic pain, I put the gymnast because I see a fair number of gymnasts, and you can imagine just looking at the posture on her back here that there's a lot of repetitive motion, and these kids practice a lot. So as they get more ingrained with this and they practice more, they do start to get some postural weakness. Typically, even though these are great, strong athletes, a little bit of ab weakness, you create this hyperextension. As it repeats itself, we get some more rotation. This creates more pain. They're having pain at school. They get bad ergonomics. They slouch. They don't sleep right. They sit crooked. Again, now we get micro trauma, which goes on and on and on. It creates a macro trauma. Then they come to the office. Scoliosis. Scoliosis is still something that we see in the office, not as much as we used to. I throw this slide up because this was, as she was presented to me from her mother, the #1 rated 8th grade softball pitcher in the Midwest. And she just could not get her shoulder better, had been seen by her trainers, had been seen by special pitching coaches, and she just was having so much back pain every time she threw, they didn't know why. So thankfully, when we got her x-ray, for whatever reason, she was fidgeting, and we got a nice picture of her spine in the x-ray, and I said, I think you have some scoliosis. So the point is that rarely do we see scoliosis as acute back pain. It's still a common cause of back pain, but it gives us all these other pretenders, as I like to say. I've got butt pain, I've got leg pain, I've got arm pain, I've got shoulder pain. I have got these tight muscles along my spine or my hips. This is that same athlete, and she actually had a very significant scoliosis, but no one would know. She knew, and she'd known for a while because she wore big, baggy, bulky sweatshirts. So she had a hood around her neck most of the time. We couldn't actually see how crooked she was. And she'd been dealing with this for probably 2 years, according to Mom, once we kind of dug down a little bit. So with scoliosis, they actually do very, very well, not with this degree of curvature, obviously, with sports and daily activity. We don't really do much of an intervention unless it's more than 25 degrees. 25 degrees, there's some good research. There's some benefit with bracing. The key is to focus on flexibility and symmetry, keep them moving, just not to overdo it and understand they're going to have some symptoms back and forth. And I'm willing to bet that at probably every high school, at least around this area, there's 1 or 2 kids in the male and the female athlete range that have scoliosis that are performing very well. And they're aware of it, and their parents are aware of it, and the trainers may not even know. There's probably also a couple that don't play sports because they're afraid of making it worse. This girl's doing well now. She was referred to Riley, and she's getting better. The lumbosacral transitional segment. This is something that I'm going to be honest, when I was in medical school, I sort of ignored because I thought, I'm not going to see this. They reported as being about 30% of the general population, and I probably see this 2 to 3 times a week. I should have had a normal lumbar spine x-ray, but there's some coming up. And if you look, we've got a nice posterior spine here, posterior spine here, the transverse process. We get down here at 5'1", and there's this nice big Mickey Mouse type ear that almost fuses, and there's a smaller size here. Whoops, let's go back. So it's not symmetric here. We come over on this other view, and it's actually, I think, easier to see. And this is nice and large and comes down. So what's happened, essentially, we used to talk about fusing. As this child was developing, the lumbar spine and the sacral spine, if you want to put it in simple terms, couldn't decide what was going to happen. So it was going to fuse, become, we used to say, sacralized, where the bottom part of the spine fused into the sacrum. So this side tried to fuse but didn't successfully, and this side just got a little bit larger. But what happens, as you can imagine, it makes this junction very, very stiff. And because it's very stiff, you have to rotate more above it. And it also puts a lot of stress on the ligaments and the muscles over on the opposite side. So these kids invariably are very, very one-sided athletes. And they've kind of developed that way by virtue of either necessity or just because they realized they couldn't do things twisted the other way. And it's amazing how many baseball and softball players I see that have this. And they say, yeah, it hurts when I tried to switch hit, which makes perfect sense. This is kind of a classification without going to medical education on people. This is what we call the Alvey classifications. of the 1A, the 2A, and A is basically single-sided, B is bilateral. But if you look at the transverse processes up here, that's nice and color-coded. The larger one is blue. Two larger ones would be a bilateral, again, is going to inhibit motion. When it has a pseudoarthrosis or almost fuses, if it's a green model, and when it actually fuses down, we've got the yellow. So clearly, we're going to have a lot more stiffness at these than we would over here. But there's a loss of rotation. And again, because of the change in motion, there's going to be an increased risk of a stress fracture. So what do we have? Stress fractures. That's kind of the big 10,000-pound elephant in the room that we see so much of, and all the parents worry about, and all the coaches worry about. But oh my gosh, Alvey's going to put him in a brace again. So again, these kids come in, they've lost flexibility. They hurt when they run. They don't want to jump. Their performance goes down. They don't know why. They're just not performing well. They're mad. Their special private coach is mad. Their parents aren't happy. They're not performing the way they feel they need to be. They took a week or two off and it doesn't get better. They have pain. They just aren't getting better. And nobody really knows why. And that starts my brain thinking, all right, we've got to see this is a high risk for stress fracture. So again, it's real important in my mind. I don't treat every stress fracture the same. We work them all up the same, but it really depends on their age, the size, the gender, and again, is this a high risk or low risk stress fracture based on the sport they're playing? And I tell the parents enough, we've already had x-rays, we had a CAT scan, or you've got to get the right type of imaging to see. I mean, this is a very, very specific picture. We see this pars stress fracture here on the right side in the picture. Just for orientation, this is right and this is left. It would be like the patient's laying down with the feet towards us on the screen. But it's very subtle, and this could be missed on an x-ray very easily. It's hard for patients and coaches to recognize and accept the fact that these are very slow. If you break a wrist, we may get in a pediatric athlete, 2 weeks to a month, and that's going to heal. A leg may take two to 3 months if it's bad, whereas a spine is going to take 3 to 6 months. And it's a slow process. And the more that we bang that and push that, it can even make it more delayed and have a risk of non-union. Now, I tell them all that typically we get them back in action at about that 6 to 8 week mark, protected in a brace, but we still need a significant time to rest. Because my goal, and as moving forward with all of us adults, we don't want this to break on both sides, because once it breaks on both sides, then we can change. We go from that spondylosis to the spondylolisthesis, which I know Dr. Weidenbitter did a lecture which talked a little bit about this previously, so I'm not going to go into a ton of detail, but we don't want that bilateral injury. So how do we treat them? Most of the coaches and trainers around the area are familiar with how I do this. We use a lot of warm and form braces initially, the soft brace or the semi-rigid brace, and the classic Boston overlap brace. There's a little debate in the literature what goes back and forth and what the right way to treat these are. I stand by the numbers we have. We've got a 90+% heal rate doing this protocol. I've been doing it here for 12 years and it works really well. Nationwide, there's an 87% success rate of getting kids back to sport at the same level, no matter what you do. And I want parents and coaches to understand that we're going to get these kids back. Even the non-compliant kids are going to get back and finish their career in high school, or they're going to finish their career in college. The issue is we want them to heal because we don't want to have any problems down the road. It's a bigger issue, more than all these other things we talk about with the spine, about these stress fractures having progression towards problems later in life. So again, we have to figure out why it happened. We may need, if it's a very thin or malnourished female, or a dietary issues, I may get specific labs. We may get DEXA scans. I had a 16-year-old boy who turns out he had multiple fractures, and DEXA scan came back high, and it turns out he had hypogonadism. You would never know it by looking at him, but his testosterone was around 100, and a normal testosterone for a 16-year-old boy is probably 500. So it was pretty low. But we do find some weird things that we don't always think would be a cause of bone injuries. So we got to dig a little bit, especially if there's more than one. A couple of quick cases with stress fractures. This was a 16-year-old high school football player. He'd had 2 months of worsening low back pain. He'd had a history of a right-sided pars fracture a year ago. Saw a different provider. They put him in that soft type brace. He wore it for 6 weeks. Never really stopped playing, but said he was pain-free from May through July. It was sort of his off-season time, so he didn't really do anything. Went back without wearing a brace, and here he sees us, and he's got daily pain, and any type of extension or rotation to the left side, which was new for him, was pain. So of course, here's his x-ray, and it's hard to see, but this is the left side over here. And we talk about the Scotty dog appearance. And if you look, there's a nice little, use your imagination. This is why radiologists live in a dark room all the time. But there's an ear, and there's a nose, and this is the neck. There's the back, there's a hind leg, there's an underbelly, and there's a front leg of a Scotty dog. So we look at the Scotty dogs here, all through the spine. And when you get right down here, it's very, very subtle, but we see nice white change along the head at the base of the neck like a collar. So there's some type of sclerotic change going on here that we don't see along these other levels. Again, it doesn't project very well, I know. I tried to clean this picture up, but I couldn't. So knowing his history, we went ahead and got some labs. And of course, his vitamin D came back at 28, which for reference, that's not terrible. Institute of Medicine recommends 30 to 100. I don't love that level, and we'll get into that in a second. Vitamin D, just as an aside, is a fat-soluble compound. Most of my athletes know that I preach this back and forth. It really is a hormone and not just a vitamin. It regulates calcium and phosphorus, mineralization of bone. We need this for so many different things in organ systems, from mood to recovery to sleep, but it's so important. You have to have the right blood test. Again, they recommend 30 to 100. We talk about 20 to 30 officially is insufficient, less than 20 is deficient. This athlete was 28, so we'd be in the insufficient range. But what I tell everybody is this is what we focus on. That doesn't work for athletes. I want it to be 40 to 60 because it's been shown time and time again, bone will not heal. I'm going to say that again, bone will not heal unless we have a vitamin D level that's between 40 and 60. So this was his MRI, same patient, and we see right there is the stress change we're talking about that was visible on the x-ray. So what do? We put him for 12 weeks in the rigid bob brace, the white brace that you saw there. We put him on 5,000 IUs of vitamin D for a month, and then 2,000 IUs for 2 months. Why we chose that dosing was based on his size and weight and the fact that he wasn't really low. He was just a little low. Put him in PT after 2 weeks of rest. All my kids are sort of the same way. I want to be pain-free in a brace for 2 weeks, and then we start moving. And we focus on neutral spine, then extension spine, or flexion spine, extension spine, and get them back. At 8 weeks, he went back to football wearing the bob brace, and we got a reverse angle CT after 12 weeks. I'm going to focus on this because there's a lot of kids and parents, and sometimes even trainers and coaches. It is perfectly legal with IHSAA to play in that white bob brace. There are certain sports you can't, obviously. You can't wrestle in that white brace. You can't dive in that white brace. You can't do gymnastics in that white brace. But I have taken care of athletes that have played in state tennis championships, state football championships, state basketball championships, state football championships. I've had golfers do NCAA golf tournament and very successfully. So you can do literally every sport within reason wearing that brace. And when we got his CAT scan, here's his CAT scan. So it looks very good. There's the evidence of his new healing, and here's the older one on the right side. So that was a very, very good case. That's what we wanted. That's the outcome we like to have. He was happy. And we typically bring these kids back in a year to make sure that they're being compliant and they've healed, and get just a simple x-ray, and he's done wonderful. He's actually gone on and played in college. The second case is a gymnast. And as you can imagine, there's a lot of back issues in gymnasts. She had a 3-month history of back pain, no previous problems prior to that, but she had some tibial stress fractures 2 years ago. And her MRI, when she brought it to me, had a bilateral L4 PAR stress fracture. She was a little resistant to the idea of using a rigid brace. And along with that, because of her, we checked her level. Her vitamin D level was 22. This, unfortunately, is what happened with her. She is that true bilateral fracture, broke all the way through, didn't heal. This is that spondylolisthesis we talk about, where not only did it fracture, but it fractured and slipped. The other segments look wonderful. You know, if you imagine from 4, 3, 2, 1, that's what a nice teenage spine should look like. This is not really what we want to see. We want to prevent this from happening because, you know, this is going to be stable. She's going to get some non-fibrous or some fibrous non-union, which will hold it in place. But, you know, she has a lifetime risk of low back pain. This is, with these type of kids, shouldn't do axial loading spine exercises really ever. That doesn't mean they can't squat, but this person with these spondylolisthesis, they shouldn't bar squat. They shouldn't do deadlift. They shouldn't do cleans. A lot of functional training moving forward to prevent this, as you can imagine, slipping forward and causing more issues, because as the bone goes forward, the disc is going to go backward. And when we see this type of patient that's not been treated or really educated over the last 20 years, and they come in and they're in their 40s, they're at not a grade 1 spondylolisthesis. This bone doesn't line up here, but it lines up here. We have them see Dr. Ritter, and we talk about having a spinal fusion. So if we can prevent one spinal fusion, I feel like we've done a really good job. There are sports-related risk factors that go for all these kids, that we talk about: trauma, overuse, overload, dehydration. There are some sports like this, to me, just looks crazy. But yeah, there's going to be risk. Let's go back here. So there are non-sport risk factors. This was a pretty interesting study from 2017. It was conducted down in South America. They looked at a couple of thousand kids in Brazil, and what they found was they went with back pain. And ironically, imagine this, they found that poor posture, backpack use, prolonged computer use, and prolonged reading use increased back pain. The teaching has always been that girls have more back pain than boys, girls have more back injuries than boys. And what this study did was they looked at specifically all athletes and looked at all causes of back pain. They didn't care whether it was a disc, whether it was a fracture, whether it was a sprain, strain, and they just looked at these issues. And what they found was that gender was not a risk factor, but using a computer for more than 2 hours a day consecutive was a risk factor. Reading in a slouched position was a risk factor. Carrying a backpack on one side was a risk factor. Carrying more than 10 pounds in a backpack was a risk factor. It's kind of interesting because that sounds almost like every teenager we see. Return to play, and this is really with any type of injury, but specifically with my PARS kids. We have them rest. We do neutral spine rehab and it's pelvic stabilization. And I tell the kids up front, it's going to be very, very boring, but it's very, very important. The goal is to give them the stability to hold that spine in place so that they don't have to wear that brace forever. The brace is a reminder, the muscles and the core will stabilize. Then they move to flexion and movements. If it's going to be a PARS issue, if it's a disc issue, we start into extension movements. And again, the reverse would be, then we go to extension movements at that third stage if it's going to be a PARS, flexion movements finally if it's a disc. We move rotations and it's more specific skills. So it's not cookbook, but it does kind of depend a little bit on the kid and the trainer and the coach and the sport. The guidelines, this is where we start to see some changes. It's hard to conceptualize this in simple terms, but we know there's not one size fits all. Everybody is different. You can't train a wide receiver and offensive lineman the same way. You can't train a 9th grade athlete and a 12th grade athlete the same way. The size, the development of the kid, one kid may be able to handle 5 extra hours of training. Another kid may not handle 30 more minutes of training. They're just going to fatigue and break down. Fatigue is so important. The NCAA, they've been pushing this 20-hour rule for their athletes for D1 as a max sports and hours in training and competition. A good rule of thumb, and this has been recognized for a long time by the pediatric world, is the age rule. So if you're 14, you get 14 max hours of training each week. And sometimes I say that to families and they look at me like I'm speaking a foreign language because, well, she's 14, but she plays softball at the high school and she has a pitching coach and she's got a batting coach and she plays on a travel team and she's got speed development training twice a week. So, and then she plays 6 hours on weekends and it starts adding up and, you recognize, well, they're clearly overtraining. So as I put on here, the other issue is that sometimes we don't take into account that time in, classes like APC class or PE class, those all count towards the hours these kids are putting in each week. And it really does take a toll on their body. As adults, we don't want to work more than 40 hours in a week because our brain kind of checks out, we're tired, we're fatigued. These kids, they're still kids, their body, they can't handle training much more than about, 2 hours a day. They really need one full day without any training a week, and that includes games, and they probably need 2. I can't say research-wise they need 2, but I recommend 2 for my kids, my own kids, my family. I take 2. I say they get a full day without training, and they can get a day for flexibility, for yoga, for Pilates, just for core, for walking, just kind of recover, things like that. Active recovery day is very important mentally. I use this picture because this is a picture of my daughter and her best friend, and they're both freshmen in high school. One is 5 feet tall, one is over 6 feet tall. They both play the same sport on the same team. I don't think it takes much logic to understand that you can't train these two girls the same way. They both have risk factors for very different type of injuries. But this is what high school is about. This is what middle school is about. We're all different sizes. And if we think we're going to train these kids and have the same expectations from them physically, then that's why we're going to get set up with more issues and more injuries. So how do we prevent this? Regular fitness and a diet, yes, normal things we all learned in health class, way back in high school. They need a dedicated day of rest. They need an off season and ignore the core. My wife pointed out after I put these pictures in here that this actually says cigarettes, and I'd forgotten that these were actually way back when you bought cigarettes at the turn of the century, they were supposed to be health aids, and they would include stretching guidelines and health and fitness tips for men and women inside your pack of cigarettes. I'm by no means promoting smoking, but I think it's interesting that even then, while they're telling you smoking is good, they knew that flexibility was important. And we just don't do a very good job sometimes of staying flexible. And we want to train, we want to get fast, we want to get strong. We really, really need to spend time in flexibility. The other, it's frozen again, sorry. Water. Kids are doing a better job of water, and I think that while I don't love the idea of carrying a plastic water bottle around all the time, getting water is important because when the muscles fatigue, then they're going to have tightness, and that tightness starts to more injury, etc. Again, this is the kind of stuff I spend a lot of time educating families and parents about, and the trainers are going to be very good with this, as are our therapists. Lots of foam rolling to break down some of the fascial changes. It's going to help us with stability. Lots of core stability training, keeping people active and a little more creative than instead of just playing games and doing traditional strength training. So what is our summary of our risk for all back injuries? Is gender really a risk? Weightlifting, multi-sport athletes, developing and growing posture, things like this. So, equal. Male and female high school athletes have the same risk for almost all these injuries across the board. And that's because of how we train and the fact that there are just as many girls that are year-round athletes as there are boys. Weight training, specifically bar squats, bar clean, bar deadlift, kettlebell swings, anything that creates that hyperextension rotation injury or a loaded spine as we get more forward flexion down low. This creates risk. The multi-sport athlete, what I call double dipping. So we just had a patient we were talking about this morning in the office who is recovering from an injury in basketball and trying to recover and come back from a very significant basketball injury and start training soccer. And the soccer coach is not understanding why the basketball coach is trumping what the soccer coach wants, because we should be training for soccer right now too. So while I'm a firm believer in multi-sport athlete, I think it's great. We give the muscles a rest. I don't let my own kids do two sports at the same time, and I'm preaching about that very seriously, in the fact that we need a beginning, a mid, and an end to each season, and we actually need a little bit of an off season. I would love it if we could have a 1 or 2 week mandatory time between a fall sport, a winter sport, and a spring sport. I love the idea of the dead week in July. I think it's important for these kids. So we see a lot of multi-sport athletes that have two sports at the same time, and they start breaking down. Developing and growing, I showed you a picture of my daughter and her friend there. Again, the late bloomers versus that middle school to high school transition. These are the kids that start having these breakdowns. Posture, what you talked about, computers and backpacks. I don't know what to do as I sit at our couch, crunched over my own laptop. They're part of what we are and what we do and who we communicate every day with, but there's got to be something made actively to get us to move more and to work on active pipe, trying to sit up straighter. Sport-specific training and sport-specific things. The baseball player with the hyperextension rotation, the wrestler with the throwing, the gymnast with the backflip, the person that's doing 100 extra serves for volleyball, all of these motions, the soccer player that spends an extra 20 kicks per day doing corner kicks, all of these rotations take a toll. Of course, just overtraining. I use the example of, the 14-year-old gets 14 hours of train a week, the 12-year-old gets 12 hours a week, the 16-year-old gets 16 hours a week. Is there more benefit doing 6 days of training and 1 day of rest versus 5 days of training and 2 days of rest? I go back to way back when I was in high school. I remember Saturdays after football, we would go in, we would stretch, we would jog a little bit, we would do a little bit of a walkthrough on plays we messed up, and we'd watch film and go home. And I think there's still a lot of coaches that do that. But having been on a sideline now consistently since about 2006, I know there's a whole lot of coaches that more or less have a full practice on Saturday too. And I don't think that's a great way to do things. And again, I'm not picking specifically on football, but I do think there's benefit in this 5 days of practice and 2 days recovery. Here's some resources we can look at, kind of show you where I found some of these things. And thank you. I'm going to stop now. I told Scott I would not talk 55 minutes, so hopefully I haven't gone to that, and we can open up for questions.
Thank you very much, Dr. Alvey. That was great overview. I loved the cigarette cards. How awesome is that? And that guy was flexible too.
Yes.
He's been working on that. Maybe the cigarettes help improve flexibility, and maybe that's a new study we need to look at.
Oh, I don't want to do any studies with cigarettes.
You know,
we'll talk to Rick.
That might be a little dangerous. Yeah. We've done quite a few of thes webinars now, and I hope we don't sound too much like a broken record, but it's not like any of you, the previous presenters, have talked to each other about what we are putting out there, but overtraining, putting these young athletes in too many sports and putting too many pressures on them has been a recurring theme in what I've heard from our specialists. Check your mic real quick.
Okay, how's that?
There we go. One of the questions I try to ask for all of these, because I think we have a lot of athletic trainers in our audience, is when do you make the decision, or when would you advise them to say, look, Jennifer, Johnny, we got to hold you out from this game. I am concerned about your back pain. I don't think you should be playing right now, and we should send you to the doc to get checked out.
Okay, fair question. What I've told the trainers that I work for through my high schools and colleges is pretty simple. If you're worried, I got your back, number one. Number two is put them through a functional progression. If they can't pass a field test, they can't play. And it doesn't matter whether it's an ankle, an elbow, a knee, a back. They should be able to do, the simple field test we do time and time again for football or for soccer or for basketball. If they can't get through that, then they're not ready to play. And if they get through it, but they don't look right, and there's still just something esoteric as a trainer, you know Susie, and this isn't Susie, then I'm going to support you and say, you know what, I think you're okay, but I agree with your trainer, Scott. Scott did the right thing here because we want to be safe.
Yeah, that's perfect. What would you say are the biggest red flags for an adolescent athlete with low back pain and or other symptoms? What would you say are the biggest red flags we should be worried about this?
Sure. So, I mean, the biggest red flag obviously is going to be any muscle weakness, any limb weakness, any persistent neurological change. My big toe's been numb for a week and I didn't want to say anything, and now the front of my shin is numb. That's a red flag. If they're not sure, I've never, and I mean this in the last 12 years, I've never had a high school athlete talk about a bowel or bladder issue. That's in the list of things, but I've had adults do that, never an adolescent athlete. Pain that just continues to escalate. Escalating pain is an immediate red flag. It was a 2 out of 10 when it happened. It moves up to a 4 out of 10, and now we're a week in, and it's a 6 out of 10. And man, they're not getting any relief with the treatments we're doing. We're resting, and they say it's getting worse. And the last thing I would say, an immediate red flag, is if they can't walk. If they're in so much pain they can't walk, then just get them seen immediately.
Yeah. Really the few kids that I remember not clearing myself from a musculoskeletal standpoint for like preseason physicals, right? Helping out the high school, got hundreds of kids coming through, flying, and most of that, like you said, is history, figuring out, hey, what's going on. But it's the back pain that often I red flag them and go, you've had escalating back pain. Now you can't do a squat. It hurts you at night. It's waking you up. This has been going on for a while. We got to hold out and get this further evaluated. Amazing how many kids I saw a few weeks ago who their hamstrings are so tight They can't bend over to the ground. They have low back pain too, just from playing sports. Do you have any recommendations for them as far as these are the stretches you should be doing? Maybe you should get involved in yoga. It's so everybody's got it. Everybody's got tight hamstrings. How do you address that problem?
Sure. Well, I mean, the first thing I would say is I took a couple of slides out for the sake of time, but along with that posture study, when they show the people kind of hunched over, the lower half of the body does sort of the opposite, and the hamstrings get tight, and we get this pelvic tilt. And we're doing it to ourselves as a society because we spend so much time seated, so much time driving, so much time crouched. And most of sports, we train pushing forward, powering forward. We don't spend a lot of time opening up. So that's the benefit of the yoga, the Pilates. And I am a firm believer. I'm a member of the Back and Neck Club, kind of like you are as well. And I tell everybody, if I had discovered yoga as a high school wrestler, I would have thought it was corny. But when I see the benefits that I discovered at 35, huge difference, huge difference. And more teams are incorporating that at the collegiate and professional level. Even if it's just doing a simple downward dog, upward dog, mild flow type thing, but getting better hamstring flexibility is key. And again, if it's a throwing athlete, you know this as a shoulder guy, they start to spin hunch. We see it in the scapular compensation, but what's that doing to the back? What's that doing to the lats? All that thoracolumbar fascia. So, I'm a big proponent of the FMS. I think it works well. It's quick and easy. I know all of our therapists could do it. Many high school trainers can kind of screen for that. There's some definite benefit, but most kids, this is not a plug for anything specifically, but most kids are very resistant to do yoga. And I tell them, hey, find somebody that has a Beachbody account and go to like the P90X yoga. There's like a 3-minute, and it's made for athletes. It's big, fit, strong people. And when they try that, it kind of opens their eyes up. Oh, well, yeah, this is hard. This was a good workout. And now they can make that one of their active recovery day. That's a great active recovery day.
Exactly. And some of those things can be built into a warm-up or cool down program, even within a practice or a conditioning program at a school. It doesn't have to be an hour hot room yoga class. It can be some of those same things built into what you're already doing. I just a few notes. I think just remind everybody that's on here, please use the chat function on Teams to ask questions or make comments. We can try to address all those during the webinar. With my experience, my stuff, which required a surgery from a disc herniation, started off as muscle soreness. And like you said, maybe you didn't do a good job with that patient asking the right questions. It was in the hamstring. A lot of this is referred pain in the nerve distribution down the leg. So it can be the glute, it can be the hamstring, even the quad or calf muscle, and ruling out any weakness in that muscle is very important. So just being aware of that. You reiterated that, but I just wanted to say it as well. One of the things you talked about was bracing, obviously with scoliosis or pars defect or stress fracture. Bracing is only as good as the adherence to wearing the brace.
That's right.
Right? That evidence is there that it will work, it will help the athlete, but if we're not wearing it, it's not going to help.
No, you're exactly right. I actually have a very candid conversation with mom, dad, and athlete before we make a commitment to go from a warm and form brace to a hard, rigid bob style brace, because there are practices around the area who don't believe in that brace. They actually say, no, it's not necessary. And it's a financial commitment from the family. And I say, listen, this is what I do. You came to me for my opinion. This is what I would do if it was my back or my children's back. But I don't want your parents to spend money on this, and I don't want you to say you're going to do it if you're not going to do this. If this is, you wouldn't go have a surgery on your knee if to tear your ACL and have it repaired unless you're going to do the rehab the right way. So this is not surgery, but understand this is to hopefully prevent a surgery in the future. And if you do this, I feel very confident saying you're going to get better, and I'm going to get you back to your sport where you were. If you don't want to do this, that's okay, but then don't halfway do it.
Yeah.
And usually when we have that type of conversation, it works out very well. We've had a few people that say, okay, well, I'm fine with that, and they leave.
Yeah.
But when they understand that, you have to wear this to work, I say you wouldn't wear your shoes without laces in them. So why would you wear your brace loose? Or why would you wear your brace in the morning and take it off when you go to school?
Yeah, great points. Yeah, it's all about convincing them to buy into the treatment plan.
Mm-hmm.
You've got to be invested in it, for sure. Well, that was great. Thank you
Okay.
for the time and conversation. Uh, IHSAA state finals track and field are next weekend in Bloomington. So if anybody on the webinar is going to be there, please swing by the medical tent, say hi. I'd be happy to meet anybody I don't already know and just have a chit chat. We've got some great webinars coming up in the upcoming months. We've got a heat-related illness webinar, which will be important as we get into the hot summer months for football. We're going to have a coach's mentality kind of fireside chat with Coach Scott Bless from Bloomington North football. And then I've got a good friend, sports psychologist at Cameron Institute, University of California, Berkeley, who's going to talk to us about sports psychology and young athletes. So a lot of good things coming up for the summer. But otherwise, please give us your feedback. We'd love to hear it, and have a great rest of the day.